Hi, everyone. My name is Marielle Malana. I'll be one of the hosts for Global Grand Rounds with Global Offsite Care today. Thank you all for being here. And as a friendly reminder, this presentation is CME approved. So if you would like to receive CME credits, please do so through the link that I will put in the chat. This video will be posted on our on our YouTube channel within a couple days. So I will also put the link to our YouTube channel in the chat. Other than that, I think we are ready to go. We have our Global Offsite Medical Director, Dr. Pekia, who will now introduce our presenter for today, Dr. Chang.
Hello, everyone. Welcome back. And for newcomers, so glad to have you on board with our monthly series of Global Grand Rounds hosted by Global Offsite Care, dedicated to advancing telemedicine for the underserved globally, which is how I met Dr. Chang, at least virtually, in the world of global telemedicine, and also spend my days as Director of Telemedicine at Western University of Health Sciences, comp in Pomona, California. So Dr. Chang, by way of her brief bio sketch, is the immediate past president of board of the directors of NGI, if I'm saying that right, a nonprofit supporting their health clinic in rural Uganda. She's an associate residency program director for family and community medicine at University of New Mexico. I see some residents in the meeting today, assuming that they are from that program, and welcome to you all. She's also the current chair of the Society for Teachers of Family Medicine Global Health Educators Collaborative. And her interests include global health equity, practice management, and electronic medical record optimization. Quite a challenge, and to be sure, in my own experience. Her work with NGI includes development and ongoing maintenance of the open source EMR that they've used on site there for over 10 years, serving as their on-site director of clinical services from 2011 to 2013, and implementation of ongoing clinical education via messaging apps and now teleconferencing platforms, which she'll be talking about in detail today. So Dr. Chang, welcome. We are all excited to have you here today, and I'll hand the gavel over to you.
Opportunity to be here today. I was asked to bring some interesting cases that may come up as we do this, work of collaborating across the, I don't know what to call it. It's not just the ocean waves, right? It's the electronic waves. And so I went back through a few years of my WhatsApp messages and pulled up some cases that I hope will be not only interesting, but offer us some highlights related to, whether you are someone who's asking clinical questions to a consultant, or whether you're the one receiving these types of questions, and trying to do the best for the patients that we can together. So I'm intending this to be an interactive session. So, but I also am time limited, so I'm only going to wait a small fragment of seconds for people to either chime in verbally or by the chat as we have some questions that I'll go through with these cases. So, and without further ado, this is our rural outpatient clinic consults. Most of these were by WhatsApp, and hopefully we can look at some cases and principles and review them together. And I have no financial disclosures to report. And hopefully by the end of this, if you don't already have some standard formatting that you are using in asking or in clarifying clinical questions in these types of clinical consultations, I hope that you'll have some ideas of what you could do with your own practice. And also, if you have a personal checklist of questions that you want to add some of my suggested questions or add to your checklist, this is hopefully an opportunity to do that. And we'll discuss some ways that local context consideration comes into play. So number one, this is just to get a sense of, kind of what's out there. So you get this is the picture that comes across on WhatsApp, and you think, gosh, that looks not great. And this is the text that comes with it. Okay. So we have a 13-year-old and difficulty swallowing, some trouble breathing, and you see some swellings at the back of the tongue per history. It's been going on for a while and relieved a bit by medications, but comes over and over now. And you can hear the child breathing. And so, and just for full acknowledgement, I want to thank the different clinical officers over the years that have they've worked with. It's been a privilege to do that. And some are at our clinic still, and some are have gone on to start clinics in their home districts and elsewhere. And so these are kind of a mix of cases de-identified across all that. What are your initial thoughts? What other information do you want to know?
Can they specify for what experiencing the difficulty, what does a while mean for a while?
Sure, right. Is it like an Albuquerque, the New Mexico minute, which could be 60 seconds or 6 years, right? It could span a large range of time. What else?
What are the medications that it's relieved by, if they know the names?
Right. So, thinking through, what else do you want to know, right? How long has it really been going on? What does a while mean, right? What do you think it is? Just at a glance.
Strep throat.
Sure. Okay. Could be strep throat. Causing what going on?
Tonsillitis or tonsillar hypertrophy, maybe the
Sure.
cryptic version of it.
Right. So thank you for playing. So so we think about what is the initial thing we think we're dealing with, right? And then the question is that the correct diagnosis, right? And then you start asking more questions like, how long has this been going on? What do you mean by coming and going? Does it actually go away all the way, right? What have you already tried? Did it work, right? And so what do we know about tonsillitis? What's the most common cause?
Inflamed tonsils.
And what inflames the tonsils usually? What's the trigger?
Strep.
So from your bacterial side, yes, right? That strep is a very common thing. And even more common than that is the viruses, right? Like, so a slew of different viruses can also do that. But, right, if we think that we potentially have something we could treat, we could test for strep. And then what do you do to treat strep? Penicillin, right? And then what are the red flag signs for this issue that we're looking at? Does anything worry you?
Possible airway obstruction.
Sure. Right. The first thing said, you can hear the kid breathing and he's complaining of trouble breathing. Right? So questions for the cloud out there, right? Is referral needed? Right. And then when do you want to follow up to make sure that this is getting better the way you expect, or we need to change what we're doing? Right. And so diagnosis here, tonsillitis with some significant hypertrophy. This is a slightly different view of the exact same view. It came in a slew of about four pictures of this. And the additional information was, village people, money is like money, to which I said, breathing is like breathing though, right? And then do you think cephalexin can be good? That was a good question. They said they went to a certain drug shop, got some Ampiclox, which is ampicillin, cloxacillin, and then Pen B, but this time it didn't make any difference. And then the question is, can anti-inflammatories help? All good questions, right? So these are actual screenshots from my phone, I think at, it was 2:45 a.m. But some of the things that I look for that I don't know if you already have in your practice or could think about including is a visual is always nice, right? When we're trying to anchor ourselves on, is this what I'm looking at? And then am I talking to somebody else who also has the same visual image of what I'm thinking we're looking at, right? And so just finding tonsillitis. And then when Googling, right? The skill of Googling is not necessarily to doctor by Google, but it's to look for information encapsulated in a way that could be a nice, all the things you need are on this screen to get us onto the same page, right? And so searching is a skill to develop, and then finding very specific answers as well. So some of the things just as an example that in my practice that I look at are pictures of a standard reference, right? That can help orient the person that we're looking at the same thing, talking about the same thing. And then something that's an easy to read at a glance, doesn't need a subscription to get into it, right? Like summary article, right? But sometimes these patient education examples are also super helpful because it's not super hard to glance and skim through, right? But you also don't want to get too far into the weeds as well. So an example, this was from those previous pictures, but something like, this Mayo Clinic has a fantastic summary of things to do for basic tonsillitis, right? But the reason we went a little bit deeper was what do you do when the tonsillitis isn't responding to your regular stuff, right? What's the next step? And so in this case, right, Michigan has a nice option here that says, when do you take out those tonsils, right? What's that next step? And so these are, I think, actual examples that I sent over. And then what do you do with the option of, we have a resistant case and your penicillin version is not working, right? And this is an article that I found that looked at azithromycin instead. And using the cephalosporin as an option as well was included in this study. An additional study here was comparing specific to the pharyngeal tonsillitis, right? And found that the cephalosporin did better in this case and had fewer side effects. So it's not an unreasonable thought to say, what about cephalexin in this case? But knowing that this case already tried the penicillins, was more severe and hadn't responded, right? We went a little bit further. And then the next thought here was would NSAIDs help? And so you can actually find evidence on NSAIDs do seem to help, and there's some decent evidence that ibuprofen relieves pain better than acetaminophen for this type of thing. So fantastic, right? Sent all those things over by text. So a couple highlights, and let me know if I'm going too fast, but I'm hoping to cover a few highlights with these as examples. So antibiotics, it's a common question, right? And in whether we're practicing in the US or anywhere else, antibiotics are a common question. And having reference sources that can help build knowledge, right? Like teaching to fish is very helpful. And also looking at practice guidelines helps familiarize all of us with, looking at them and finding them for next time. In local context, though, sometimes getting the medicine can be too costly for someone to complete a full course, right? So in this case, we talked about azithromycin based on what I found, and then referring for an ENT evaluation because we had such crowded airway, right? That was an issue, and then trying some NSAIDs for pain relief. Okay, next case. We have a 24-year-old pregnant female with severe abdominal pain that can be 2 to 3 days out of a week. She's at 34 and 5 weeks gestation and has some abnormal discharge, GDM diagnosed with severe urinary tract infections throughout the pregnancy, and has tried a bunch of different antibiotics, including ceftriaxone, cefixime, nitrofurantoin, got some clotrimazole pessaries, which helped for a little bit with just the discharge. And every time she comes in for antenatal has pus cells, more than 100. So I asked for more information, right? So what is she still experiencing? She still has this pain, right? It's an active ongoing thing. And she's getting painkillers, which include diclofenac and paracetamol, which is acetaminophen for those in the US. They did check the baby, ultrasound looked okay. This is their first pregnancy. GDM did not require treatment based on the glucose level at spot check. And she is seronegative, meaning HIV negative. And last got some ceftriaxone for 5 days. And then it came back again. So what are your thoughts?
And just to confirm that not contraction pain and her blood pressure is probably fine too, right?
I'm going to say yes.
Okay, just, they didn't say that, so that's good. Just
Yeah.
thinking.
Those are great thoughts. So she came back with some results for you, right? This is her urine chemistries up top, and she had a urine culture as well that she came back in with, right? So they circled it up here. This is GBS, and they wrote out a diagnosis down here that this is a streptococcal UTI. And we'll talk about some of the nuances here. Is this an infection or asymptomatic? What would you think?
There's no mention of any, that she's giving any urinary tract symptoms like burning or frequency or something like that. So I'm kind of curious about that part of it.
That's true, right? Yeah, because you can have bacteria in pregnancy and we don't necessarily do something about every single thing, right? But she does have, right, this ongoing abdominal pain, right?
Right.
And significant amount of, it doesn't say, you know, if it was a super dirty catch versus, you know, they've got plus West epithelial cells here, right? So the pus cells being your white blood cells. So it could be that it's a dirty catch urine, right? And it didn't quite get a clean sample as far as like, you know, doing the culture, right? But it is GBS positive. It doesn't tell us whether this urine culture is 10K, 10 to the third, 10, it doesn't say that. And so what I have to base this off of is just that it's diagnosed as, you know, streptococcal. And, but she does have some significant ongoing abdominal pain off and on that doesn't seem to be labor, you know, according to the information we're given. Right. So what are the risks of, let's say it is an infection, you know, and what are the risks of treatment for this lady?
You know, antibiotic selection, it might be adverse to, you know, to the baby in utero.
Right. So, you know, some of the options here, we know ceftriaxone has already been given and actually is in guidelines, so it would be safe to use. Some of these options it's resistant to, but you wouldn't want to use them anyways, right? Especially the cotrimoxazole or Bactrim in US terms here, that nitrofurantoin, depending on, you know, how close you are to delivery, right?
But then
Is it
risk
worth
of allowing the infection to go on is preterm labor.
Sure.
So
Right. And the fact
part
that it's
your
GBS.
question of worth treating. Yeah.
Yeah. So, and you know, the risk of neonatal sepsis with this baby, is it intraamniotic? You know, is it currently just related to urinary tract? Is it or is it not? Right. But could it become an intra-abdominal, you know, intraamniotic infection, right, and cause significant morbidity, mortality in that way? So the question then is like, what do you treat with? How long do you treat for? Right. Any other recommendations? So they circled, you know, co-amoxiclav, right, which is augmentin, amoxicillin clavulanic acid. But she's already had the higher dose IV versions, or at least IM, and it's not, you know, been sufficient at 5 days, right? So we're going to call this a recurrent GBS UTI in pregnancy for the sake of, you know, wanting to do something since she's having issues, ongoing issues, right? So I'm going to make here a plug for, there are some helpful finds that we found for this case. And one of them was a fantastic review article on UpToDate. And if you don't have access to that, or your colleagues don't, there is betterevidence.org that offers free online, you know, applications for those in other countries that they essentially do an application and can get access to all these things on UpToDate. And there are some great articles, you know, on what do you do in pregnancy management, right, of this and antibiotic therapies, right? And the question being, is this just a cystitis? Is it a recurrent cystitis? If we're going to treat it, is it a pyelonephritis, right? And if this lady is outpatient versus inpatient, how long do we treat for, right? And so the specific options include, I like this one here that I found as we were going through it, and actually sent this review article over as well. So the consideration being, this is somebody who is pregnant and has not improved yet. So probably needs to go up to the IV version. already did the 5 days and that didn't work, so probably need to go up to 10 to 14 days, right? And she's very close to delivery, right? Otherwise, if this is something that has been ongoing, at what point could we have thought about preventive, prophylactic treatment for this lady as well, right? So in this case, right, the suggestion sent over was, why don't we repeat the ceftriaxone and the clotrimazole since they seem to work, but a longer duration. But then take a look at those meds that we were given, right? Why are we giving an NSAID in pregnancy as the painkiller? There are some danger things, in pregnancy as far as, ductal closure for the baby and so forth. And if you're wondering, right, let's go ahead and double check. So because I know that ceftriaxone was in the guidelines, so that's a recommended course, but I don't remember about clotrimazole. So I'm going to come over here to my up-to-date and look in this LexiComp that is connected here. Has anyone used that, or does anyone use that routinely in their practice? The up-to-date LexiComp link, right? So it's connected to a great pharmacy resource that our pharmacy colleagues use all the time. And you can actually type in the name of the medication here and it will pull up your options, and not only dosing, but also pregnancy considerations, right? So coming down here to the pregnancy considerations, is it okay to use vaginal in pregnancy? It looks like it's okay, right? Because I couldn't remember, so I check. But if this lady was a little bit earlier at 35 and, some weeks here, that probably a little too late to do prophylaxis, but something that we could have considered earlier. And Dr. Vecchio said, this is a pregnant patient. Is she having labor signs, right? To look for those things. So some highlights, all right. Medication choice and indications are different in pregnancy. So, and don't forget to assess the pregnancy, even though we have a different presenting complaint. All right. But some of the things that came up, and I don't know if you saw that, is the seronegative status, right? Essential in the population that we work with. When we lived there a decade ago, it was like 11% population prevalence of HIV. It's dropped some for the overall prevalence since then, but that's a lot of people that we need to know whether or not they're at higher risk for overwhelming infection, right? And other things might signal escalation of preventative care, right? Another point with this local prevalence thing is that cotrimoxazole was on the list, even though it was resistant, and we wouldn't use it in pregnancy in this case at this time in pregnancy, but there's high resistance rates in our local area because of the high HIV prevalence. And so the cotrimoxazole is used in prevention in HIV. So it's ubiquitous everywhere, right? And so it's not easy to use it to actually treat other infections because of the resistance pattern. All right. With these couple of cases, you see the information comes in. There's a lot of information, but then there's more information that you might want, right? And it's very helpful to have a standard case structure we've found when trying to organize a question so that you're not missing important details, right? And that the consultant is able to, pull up the information needed to help answer the question. And so there are many different tools people use. Here's an example of one that you can find on the IHI resource, but something like SBAR, right? Has anyone seen this used in your work context? Our nursing staff uses it a lot, right? But mainly it's just a way of saying, this is the situation I'm asking about. Here's the background behind it. This is what I think is going on and what I think we should maybe do, or what type of recommendation I'm asking for, right? It helps focus that question in. And we found that has been helpful, in not having to go back and forth by text a million times to try to get the answer more clearly. And then working through key assessments. So these are some of the questions I think about that have been helpful. So, Dr. Vecchio's earlier question, how acute is this? Is this something that's been going on for a week? Is it going on for a year? Is it something urgent, or has it been stable, right? Has other stuff worked in the past? Are the resources available, and how much do they cost to actually do the treatment that we're thinking of, right? And what's the follow-up plan, right? Is there resolution or not? So because figuring out what's going on is only half of the problem, right? You have to figure out how to manage it in the context. So I got a twofer here. It came as a double, both on back pain, and we're gonna look at the first one here. This is a 67-year-old, long-standing back pain radiating to the lower limb, gets relief on analgesics, and they sent him for an x-ray. Came back with a compression fracture at L4, and there was also radiculopathy. How can we help him? Right. So do we have the information that we need? Situation being a 67-year-old with back pain goes down to the limb and has been able to be relieved with analgesics, right? And we know that he has a compression fracture, and then the recommendation was left open. So is this something acute or chronic?
Right.
Seems
And,
pretty
and yeah, and additionally, yeah, some of these other questions about duration, other comorbidities. Also, yeah, under assessment, gee, what does the assessor actually think is going on? It can be very helpful to have at least a small differential diagnosis as part of the assessment. And then not just questioning how can we help him, but what would the assessor actually recommend be done? And it help. And I think the point is it helps in the conversation and moves it along more efficiently.
Yep, exactly. So, so this case, this was all that was presented, and in light of the second case, so we'll see in a little bit here. This was all the information I had, and we went along to say, well, we have a 65-year-old plus, gentleman with a vertebral compression fracture. They didn't mention anything about trauma. They didn't mention anything about other symptoms like, does he have a potential like metastatic cancer to the bone or anything like that. But if we're just talking about a simple vertebral compression fracture causing this pain that's relieved with analgesics, right? Sounds like let's continue the analgesics. The goals of treatment usually in a vertebral compression fracture is conservative management for a few weeks, right? And prevent future fractures, right? If this is somebody who is at risk for creating fractures, and hopefully restore that function. And this sounds like it's been ongoing for long standing. I'm going to assume that it's been months, if not years, of this going on. So looking at bisphosphonates, right, in that window does have evidence and to prevent future fractures. And I used to think that it was, you had to wait a decent amount of time for months, past that acute fracture. Found that this nice Barton article here said, more than 2 weeks seems to be enough. If it was the acute stage, you could get some calcitriol. I don't know that that's available in the location this person was texting me from, but the bisphosphonates is a possibility that they could look into, and clearly avoid smoking or additional steroids. There's also a nice AFP article that summarizes this, and I don't know if it's going to open up on. This is a glitch in my system here. Right. But you can find some real nice articles that summarize this for future reference, right? Because this is probably not the only back pain vertebral compression fracture case that this clinical officer is going to face. And so providing this resource that lets them review, what are those risk factors, what things are you looking for, right, in this case, and what's the treatment pathway. So that's what we went with. But then we had the second case that came in on the same text. So a 23-year-old presented to the clinic with lower back pain for 2 years. 2 years ago was treated and he got better. And then 1/12 woke up in the morning with bilateral limb weakness, couldn't support himself to stand, failed to pass urine. On exam was muscle power 3 out of 5, was catheterized because he couldn't pass the urine and he couldn't pass stool. Sent him for a lumbar spine x-ray, and it showed a disc prolapse at L5, S1, and fractured pars at L5. And then that was the assessment. And then the question was, what type of physiotherapy can we help him with, and any medication for him? So the S-bar, right? The situation, we've got somebody else with back pain, but this case, it's a 23-year-old, right? And there's a history, a background of having back pain 2 years ago that got better with treatment. What are your thoughts?
As the Zoom silence continues, encouraging as one or more of my own students to chime in with how they would actually augment this an S-bar to kind of move it forward.
I was saying, can you hear me now?
Yes.
Yeah, I'm saying that for me, my thinking on question one is what type of physiotherapy can we give him? We can give him the lumbosacral physiotherapy to try to relieve the tension on the disc, and then on medication we can put him on NSAIDs since he's just 23 years old, and with maybe the Cossack, the back Cossack can help relieve that tension. That's what I'm thinking.
Sure. Yeah. And I think that was the initial thoughts, right, from the officer that sent this case over, because it's back pain. The previous case was a compression fracture with radiating pain as well, and that was the thought of the course, especially in light of the previous patient as well. So I'm going to bring up a few things on this case that stand out. Okay, so for those who are not from places that use 1/12, this does not mean January 12th the patient woke up. This means 1 month ago. This has been going on. 1/7 is 1 week, right? 2/52 is 2 weeks. 1/12 is 1 month. Okay, so the acuity of this situation, it's not 2 years. It's actually this patient woke up 1 month ago with bilateral limb weakness, couldn't stand, and then lost his bowel and bladder control, which was corroborated on muscle power weakness on exam. Okay. The urgency stability, is this a stable issue?
No, and the worry, of course, is possible cauda equina syndrome.
Yeah. Right. So there's a difference here with seeing the same thing as back pain and wanting to relieve the stress on the nerve roots, right? And this is actually a different issue, right? So the previous treatments 2 years ago, I'm going to say that was a different issue, okay? Because this is a 1 month acute issue, leaning almost towards no longer acute, right? Because the time is moving. So then we're worried about resource availability and costs. So just as a reminder for this case highlight, so having a herniated disc is the pulpose of the inside part of the disc is squishing out, right, and putting pressure on the nerve root. But in addition to that, this patient has a fracture here in the pars interarticularis, which sometimes there are congenital defects without other issues, right, and that can be not a non-issue, but this person has both a herniated disc and a fracture at that same level, and we have loss of some things, right? So in this case, we have a herniated lumbar disc with a pars fracture with neurologic function loss, which is a red flag, okay? And we'll talk about red flags in a little bit. But the actual treatment here would be urgent surgical referral because of some of these red flag issues. So if you just have a slip disc, meaning a little bit of pressure is coming out, sometimes our non-surgical treatment options can help that. So as Dr. Otto said, right, you relieve the pressure on that nerve root, and that disc can kind of suck itself back in if we give it enough time and do it properly. Okay, usually in about 6 to 12 weeks, we'll see resolution. If we have cauda equina syndrome, where we have significant compression with these neurologic findings, this is an urgent emergent type of situation. So this is a highlight of there are some spinal cord emergencies that I really like this AFP article, and you can have access to these slides afterwards if you are looking for these articles. But the reason I'm pulling this up is there are some nice summaries of what do you do in the case of emergency? What is an emergency? Okay, and this one has a nice flow chart diagram of going down those things. And in the vein of finding things that are quick, easy reads, Tenet Health here also had a nice summary statement of, what are the red flags that you're looking for in this type of a case? So severe back pain, which a lot of people have, right? But weakness in limbs, lack of bowel or bladder control, sharp pain or numbness and tingling. So this patient had a few of those things, and we're talking about these types of emergencies, okay? So some patients can't afford the appropriate management for certain things. Like I could say, hey, this patient needs to be referred, okay? But maybe he can't do it. But if the inability to achieve appropriate management should not lead us to treating with inappropriate options either, right? So doing physiotherapy for this patient is not inappropriate, okay? But step number one before that would be assessing for, is there a surgical option that we can't, that we can get him to urgently? But at 1 month, it might be a little too late. He might have lost that function if he's not been able to walk and can't control his bowel and bladder for that long. Okay, here's this was a lot of different cases on here. And so, this came in a lot of things. So I'm going to summarize this case. This is a 30-year-old woman who had a road traffic accident, fell off of a boda and has a fracture. Okay, was seen at the referral hospital, sent home with a splint, and had a big laceration on the thigh. They sutured that and was told, come back, for wound care 3 times a week at the local clinic. And they brought her back after 3 days to the referral center as they had been instructed. They put on a cast. But because there was limited funds, this patient didn't have any personal funds, the surgeon said, we don't need new x-rays. All right. 4 weeks later, she went back to the hospital, was advised to just continue calcium, have the cast removed in another 10 days, and didn't have the money. So they said, we don't need another x-ray, just keep on your wound care. Okay. And then 6 weeks post-injury, they removed the cast. There's some swelling here. This is the picture with the cast off. And it's healing. Surgeon said, we don't need another x-ray. And then, here's a walking stick. Don't walk on it. She hasn't felt good to walk on it yet. Okay. So this is at 6 weeks, post-injury, this is at 7 weeks now post-injury. And requested that, could they please get another x-ray? This also involved sending some extra funds for this person personally to get these x-rays, because this is what they looked like. So what happened here? What are your thoughts?
Maybe I think it's the malunion.
Correct, right? This is malunion. This is not in alignment, right? There's no way that this fracture will heal in a way that will allow this patient to walk again, right? Without breaking that fibula right next to this tibia fracture, right? And so she appropriately stayed off of it because she did not feel good on that leg. But my question, right, is that all the way back, to here, we didn't have an x-ray to show that the cast had the bone in proper alignment to be able to have a good result 7 weeks later, right? And so the question with this one, so this ended up being a referral out to a private surgical hospital, and she was able to get a consultation the next day and schedule for surgery, and underwent a successful open reduction external fixation for the tibia fracture, okay? But this was at 7 to 8 weeks after her initial injury. And in this case, we lost 7 weeks of time for this patient to heal, right? Because initially getting the x-ray shows you that you have a fracture. But if there's a splint or a cast being put on, and that bone is not in alignment at that time, it's holding it in place in malalignment. Does that make sense? And so this is an option. This is a situation where acting early, having that repeat x-ray would have been very, very helpful that first few days, right when that cast was placed. And thank you. I'll come back to that question. So the case highlights on this one is, if you're looking at, something that doesn't seem to make sense, it's okay to get a second opinion, okay? Because if you're not going to get healing in where you want, and that fracture is not going to heal, right? Then we need a repeat X-ray to know that we're doing the correct management from that initial thought. Okay. These are some quick ones. 50-year-old lady, lump in the breast, and exam shows the same thing, not tender, not hot, no sign of abscess. And mammogram was not done, biopsy was not done. But the clinical officer sent, I think it's either cancer or fibroadenoma. I've already referred them to oncologist and for a biopsy. Any other suggestions? I thought we did good, right? That has all the SBAR information. I agree, right? Here's another one with long-standing lumps everywhere, and they've been growing for 5 years, but growing more recently, right? In this case, we need a biopsy, right? There's nothing I can say. Right? Chronic foot ulcer. Thank you, right? So they actually did a biopsy, and it came out as Kaposi sarcoma, right? So context is important. Knowing the local prevalence of certain conditions and risk factors, make a big difference in your clinical reasoning and diagnoses, right? That's not a Kaposi sarcoma I've seen before, but it's a Kaposi sarcoma, right? And then some patients will have some other thoughts, right? So this is a patient with, you always start with the greeting, hello, how are you? This lady has had 8 months of cough that won't go away. We've treated it with everything, okay? And we got some other exams, all right? And then they sent these pictures, and I thought, well, gosh, I'm not a radiologist, okay? But looking at it closer, I can see that maybe there's something in the right chest here that I don't think should be there. That's about what I can do for you with this type of imaging on my little screen, right? But even better, they sent you the pathology report, okay? So there's the aspirate, and there's a pathology report that this is high-grade invasive carcinoma, okay? So then what are we looking for? In this case, sometimes people just want to hear something different, but there may be nothing different to tell them, right? You've already tried 8 months of treatment. Any treatment that I offer you is not going to change the fact that you need to see the cancer center and see what options you have. Right. And this is the last case here that I have, and we'll answer some questions and review. So trouble hearing out of the left ear for an 8-year-old. Okay. It's been going on and off for a year, and maybe got treated for an infection about a year ago. And it bothers her sometimes, nothing going on right now except for the ear discomfort. And she's having trouble in school. Right. So this is an example of something that did not go well over WhatsApp because I did not have this exam until we visited. And this is an example of ear effusion. You see this oiliness, a little bit of chronic inflammation, right, with this chronic effusion. For example here, to compare, right, you can have upper respiratory infections that give you air fluid levels, and with the translucent, though, eardrum, right? Here's a couple of examples. You see these air fluid levels, but when you get to chronic stage, right, here's some examples from up to date that show a progression of increasingly chronic and purulent ear infections. Now you've got chronic thickening and probably trouble hearing, right? So sometimes this follow-up, we get to this follow-up and usefulness of if your initial thought and initial pattern management is not working, when do you follow up? It's very important to follow up because in this case, right, we have an 8-year-old who's now struggling in school, and at that point, right, in primary school, it's a very important time in their life to develop their scholarly ability, right? And if she's having trouble hearing, she can't hear the teacher, so she's struggling in school, right? And would an early referral have helped more and preserve her all that time to grow, right? So 80% of people with disability live in, regarding the hearing loss, live in low and middle income countries, and it's a lot of burden for these folks and around the world. So, regular things. So When routine complaints are no longer routine is when either you see red flags, right? Or it's something that has a preventable future consequence. Okay. All right, and that's it. So the basic things that we looked at, and let me know if I think my internet's unstable. Reference sources can be helpful, right? Some patients can't afford the medications. The different choices in pregnancy and making sure that you review the pregnancy itself are important. And local population disease prevalence is important to know, and know when to escalate the care, right? And start preventive care options. And just because you can't achieve the appropriate management doesn't mean that you should do things that are not matching the patient's need. And if it doesn't make sense the first round, get a second opinion. Okay, it goes both ways, and you have to have follow-up to know whether or not you're on the right course. All right. And when routine complaints are no longer routine, you need to do something different. So we found SBAR helpful. I find this list of questions helpful. All right. And these are some of these are the sources from today. So, all right. And looking at the questions now. Let's see here. So Dr. Obikezi said, not sure on the final recurrent abdominal pains at 34 plus 5 recurrences after good antibiotic use. So the final decision on that lady, at least for the current round of treatment, was to do an extended treatment course, ceftriaxone 10 to 14 days, probably do that IV, and then do some additional clotrimazole to reduce some of the burden of the amount of discharge that she was having. But she's very close to needing to deliver, and probably closer monitoring of that pregnancy. But yeah, so our initial thought, and I don't have the follow-up on that yet, was to do the ceftriaxone course, but extend it for the 10 to 14 days, because 5 days was shown not sufficient.
Great, thank you, Dr. Chang. And yeah, for anyone who has additional questions, feel free to just jump right on and verbalize that, or put it in the chat. We'll keep an eye on that in the 5 or 6 minutes or so that we have available. I have one burning question, and thank you so much for sharing these cases that obviously lend themselves to telemedicine capabilities, including the use on the ground of diagnostic devices that can be applied by the patient themselves. I know many of you are aware of the TytoCare type of device that the patient and or a friend, family member can utilize to transmit, saved images, et cetera, like that eardrum that we saw, or the history that we saw in the patient with, the red flag back pain, cauda equina syndrome. That said, assuming that many remote areas have issues with connectivity and or even electric power. So is there a role, from your experience, Dr. Chang, of utilizing capabilities like artificial intelligence driven chatbots that the patient and or their advocate can actually have a history taken by the software, your sort of instant medical history that's connected to an AI machine learning capability that begins to generate a diagnosis, a differential diagnosis, and can itself over time become reasonably reliable to identify red flags while the patient is actually generating the history before the clinician is even brought into the encounter. Have you used any of those, or are those coming up in your ecosystem as a potential benefit to your project?
It's a fascinating idea. We have not utilized AI yet, but if it's a computer that can learn, right? Because the local context and how people talk about things is so important. Like in our village area in Uganda, the term for fever is the same as the term for malaria, and so is how does the machine learn those local nuances? And I think that having having something like that could filter or ask questions differently. Yeah, it's definitely a possibility. Mhm.
Great, great. Thank you.
Mhm.
And anyone else with any questions?
Dr. Obakezi
Please
has
pose
his.
them.
Mhm. Thank you. Dr. Obakezi, you had a hand up?
Yes, I was raising my hand. I had already typed a question on the chat box. I wanted to, possibly I was distracted. I wanted to find out the final decision of the team managing the woman who was pregnant at 34 weeks plus 5 days gestational age with the recurrence of the abdominal pain and despite after long period of treatment with antibiotics. I wanted to know what the team finally decided and how the woman was managed. Finally, thank you very much for the cross-cutting presentation.
Thank you. So the final decision on that was that if it's not just a cystitis or a basic urinary tract infection with her amount of complications and the risk for pyelonephritis, that a longer treatment course of 10 to 14 days was more appropriate than just the 5 days. And so we elected, based on the culture results, to go with the ceftriaxone again, but to increase it to a 10 to 14 day intravenous to start with course. And to monitor her closely, as well as repeat the clotrimazole, which seemed to improve her symptomatically with the vaginal discharge.
Thank you very much.
Thank you.
Great. Another quick question. In the field, patient facing in remote environments, has there been much experience in your project with the augmenting the information in an SBAR with handheld ultrasound to that point specifically for this young lady with the ongoing, pregnant lady with the ongoing abdominal pain? Would point of care handheld ultrasound actually been additionally beneficial?
So we actually are working on a POCUS project, a point of care ultrasound project with, we have an ultrasound on site that has an ultrasound tech once a week. And so sometimes people refer into that clinic if it's not urgent, but we're actually working on expanding out the initial trainings that we've done in point of care ultrasound with our clinical officers and midwives to be more in depth, kind of 1 unit at a time for an extended point of care ultrasound curriculum. So. Mm-hmm. Probably starting with the pregnancy one first, and then kind of choosing highlights of things that are highest yield based on the staff preference. Great.
Yeah, and just as a reminder to those still on the meeting, our next speaker next month will speak on that topic. An expert, Dr. Joachim Brown of Western U. Will be presenting on the use of handheld ultrasound bedside and in other settings, and helping to sort of augment our capabilities in telemedicine. So with that, I think we are unfortunately at the end of our hour. I want to thank you again, Dr. Chang, so much for sharing with us, and just a wonderful presentation, and appreciate your donating your time and experience to us and our audience. And also a reminder to the attendees that CME, ACCME certified 1A 1 hour credit is available for up to a week subsequent to this presentation and the recording of it as well. So feel free to take advantage of that, and Global Offsite Care gladly funds the cost of that for you. So unless we have any other questions or comments, I'll hand it back to Marielle to close.
Thank you, Dr. Chang, for that insightful presentation. We are coming towards the end of our time here. If you are interested in presenting, I have put my email in the chat box. And if you have any questions, feel free to reach out. This recording will be available in 2 to 3 days, so please check out our website or YouTube channel. With that said, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again.